In this video, we'll be exploring the superior vena cava, one of the body's major veins. We'll take a closer look at its anatomy, understand how it functions within the circulatory system, and highlight its clinical importance. To do so, we will start with a brief introduction, followed by the descriptive anatomy of the superior vena cava, its branches of origin, and its anatomical relations. We will also detail its collateral branches and collateral pathways before diving into some clinical applications and the surgical approach route of this vessel. And finally, we will end our video with a conclusion. The superior vena cava is a large vein formed by the union of the right and left brachiocephalic veins. It drains venous blood from the supradiaphragmatic regions of the body to the right atrium. Let's start with the descriptive anatomy of the superior vena cava. It is located in the anterior and superior mediastinum and arises from the junction of the right brachiocephalic venous trunk and the left brachiocephalic venous trunk. The point of junction is located anterior to the brachiocephalic arterial trunk, posterior to the first chondrocostal joint, and at the level of T3. Let's detail now the branches of origin of the superior vena cava. Starting with the right venous brachiocephalic trunk. It arises from the right internal jugular vein and the right subclavian vein at the level of the medial end of the right clavicle. It then runs almost vertically downward and to the left while remaining on the right side of the midline. And it terminates opposite the first right sternocostal joint. The right venous brachiocephalic trunk is related to the following structures. Anteriorly, the sternal end of the clavicle and the sternal part of the first costal cartilage. Posteriorly, the right brachiocephalic arterial trunk, the right vagus nerve, the internal thoracic artery, at its origin. To the right, the right pleura and lung, and the right phrenic nerve. To the left and toward the midline, the trachea. Let's move to the left venous brachiocephalic trunk. It arises from the union of the left internal jugular vein and the left subclavian vein. It originates opposite the medial end of the left clavicle. It measures 6 centimeters in length and follows a horizontal course, directed downwards and to the right. Then it crosses the midline. It joins its right counterpart opposite the first right sternocostal joint. The left venous brachiocephalic trunk is related to anteriorly, the thymus or its remnants, the left sternoclavicular joint, and the manubrium of the sternum. Posteriorly, the brachiocephalic trunk, the left common carotid artery, the left subclavian artery, the left phrenic nerve, the left vagus nerve, and the left internal thoracic artery, and inferiorly, the second segment of the thoracic aorta. Let's now detail the superior vena cava. The superior vena cava follows an oblique course downwards and backwards, curving around the ascending part of the aortic arch. It ends at the superior wall of the right atrium, opposite the third costal cartilage, and at the level of T6. The superior vena cava has a length of 6 to 8 centimeters and a width of 20 to 25 millimeters. Let's explore now the anatomical relations of the superior vena cava. They are distributed in relation to the pericardial serosa that surrounds the superior vena cava in its lower part. There are intrapericardial and extrapericardial relationships. In its extrapericardial or suprapericardial portion, the superior vena cava measures 4 to 5 centimeters in length and relatively superficial. It is in contact with anteriorly, the right anterior mediastinal lymphatic chain, the thymus or its remnants, the anterior costomediastinal pleural recess on the right and the anterior border of the right lung, and the sternocostal junction, behind which the internal thoracic vessels are applied. Posteriorly, from top to bottom, the azygous vein arch, the right phrenic nerve, and the right vagus nerve. Anteriorly, the manubrium sterni, and the first right chondrosternal joint. To the left, the aortic arch, and the left venous brachiocephalic trunk. To the right mediastinal pleura and the right lung. Inferiorly, the arch of the azygous vein, and superiorly, the right subclavian vein and artery. In its intrapericardial segment, the superior vena cava is shorter, measuring from 2.5 cm to 3 cm, and also deeper. It traverses the pericardium. The fibrous pericardium ascends over the superior vena cava and merges with its adventitia, whilst the serous pericardium forms an asymmetric sheath that extends higher on the left side of the vein and is incomplete at the back, engaging only the anterior 3/4 of the vein. The line of reflection of the pericardium creates a recess between the superior vena cava and the right superior pulmonary vein, called the retrocaval fossa. The relations of the superior vena cava in the pericardial sac are the following. Anteriorly, the right atrium. To the left, the aorta. Posteriorly, the right superior pulmonary vein, and the right pulmonary artery. Outside the pericardial sac, the superior vena cava is related to. Anteriorly, the sternal extremity of the second intercostal space. At the upper border of the third costal cartilage. Posteriorly, the right pulmonary artery, and the right superior pulmonary vein. The right pleura and lung on the right. The right phrenic nerve. Let's tackle now the collateral branches of the superior vena cava. The main collateral of the superior vena cava is the azygous vein. The azygous vein originates in the inframediastinal posterior space, at the level of T11, from the junction of its two roots. An external root, that is constant, and formed by the fusion of the right ascending lumbar vein and the 12th intercostal vein, and an internal root, that is inconstant. Now, let's dive into the collateral pathways of the superior vena cava. In case of obstruction of the superior vena cava venous system, 3 anastomotic systems develop depending on the level of interruption. The anastomosis between the brachiocephalic trunks and the azygous system. In case of obstruction between the confluence of the brachiocephalic trunks and the junction of the azygous vein, the collateral pathways are the internal mammary veins, the external mammary veins, and the right and left superior intercostal veins. Anastomosis between the superior vena cava and the inferior vena cava. In case of obstruction at or below the junction of the great azygous vein, the collateral pathways are the posterior trunk system between the azygous system and the plexus of the spinal column, and the anterior trunk system between the internal mammary vein and the epigastric vein, between the external mammary vein and the abdominal subcutaneous vein, and between the internal mammary vein, the epigastric vein, and the veins of the round ligament draining into the portal system. And transversal anastomosis. In case of interruption at the junction of the brachiocephalic trunks, the collateral pathways are the system of thyroid veins and the interjugular system, internal, anterior, and external. Let's explore now some clinical notes and applications. Starting with the superior vena cava syndrome. It is the obstruction of the superior vena cava caused by thrombosis or extrinsic compression, leading to venous hypertension in the supradiaphragmatic part of the body. It involves vertigo, visual disturbances, eyelid edema, swelling of the supraclavicular fossae, facial cyanosis, and edema of the jugular veins. And the superior vena catheterization is a medical procedure in which a catheter, a thin, flexible tube, is inserted into the superior vena cava, typically through a peripheral vein, such as from the arm or groin. This procedure is commonly used in several medical contexts, such as medication administration, blood sampling, hemodynamic monitoring, access for implantable devices. Finally, let's tackle some surgical access routes to the superior vena cava. Starting with the total vertical median sternotomy. The incision is median and vertical, from the sternal notch to beyond the xiphoid process. Access to the entire superior vena cava, both intra and extrapericardially, requires opening the pericardium along an axis from the diaphragm to its aortic reflection line. Right thoracotomy. The thoracotomy is right posterolateral with the section of the latissimus dorsi muscle. The incision is made in the fourth intercostal space, which provides the best exposure of the superior vena cava. And the bithoracotomy. It is a surgical procedure that combines a bilateral anterior submammary thoracotomy with a transverse sternotomy. This approach provides an excellent exposure to both brachiocephalic trunks and the superior vena cava trunk, making it particularly useful in surgeries requiring access to these vascular structures. To conclude, the pathological phenomena of the superior vena cava can be explained by its structure, location, and anatomical relations, which highlights the importance of understanding its anatomy.